Welcome to Didactic. Today is Saturday, August 10th, 2024, and I am Dr. O'Leary, a psychiatrist and a fellow in child and adolescent psychiatry in the National Capital Region. This is a podcast about psychiatry and neuroscience, and I produce it in my free time to help inspire me to never stop learning. I hope that it can help you learn as well. Now, I should remind you, and anyone listening, especially new listeners, that I'm not giving medical advice here, and any opinion that I present here, even when I try to report on other people's opinions, is still just my own opinion. My opinion about their opinion. It's no one else's opinion. I want to say that a lot so you understand. What I say here is just me. Although I hope it's smart, it's not always. One of the things that is both frustrating and fascinating about psychiatry is how uncertain everything is. I mean, I consider myself a science-based clinician, but the kinds of science available, and in general the kinds of evidence available, really only answer a few specific questions. We don't know, for example, how our brains work very well, although we are gaining knowledge fast right now. Our brains are also not really generating anything that is independent of their environment. They're not like in a jar. They are embodied. So these complex interactions between the brain and its bodily environment and the body's environment also can't be ignored when we're trying to talk about psychiatric illness. Another difficulty is one of diagnoses. And I've talked about this a lot, how difficult it can be to diagnose things, and that is what I want to focus on today. Many psychiatric diagnoses can be difficult to easily distinguish from each other. So this is one of the reasons that the DSM has been so thoroughly revised so many times. Now, I've struggled, for example, to distinguish between something like severe ADHD in an adult, or borderline personality disorder, or bipolar 2 disorder, or something else I don't even know about. PTSD itself might resemble agoraphobia, or they might both be present at the same time. Many of the disorders that resemble each other are also present at the same time. Now that I'm a fellow in child and adolescent psychiatry, many of my patients are not neurotypical. It can be difficult to distinguish, for example, narrow interests and repetitive actions from obsessions and compulsions in patients with autism spectrum disorder. Often there's kind of a long period of waiting and observing to see what happens before a final decision is made. Even if we're having patience with our patients, I often find myself making just a judgment call in the end and being less than 75% confident of what I am actually treating. I mean, sometimes it's just a coin toss in my mind, but I have to make a decision anyway. Let me take a moment to discuss a phenomenon called degeneracy. I think this is a very important concept, and I really only conceptualized it recently. So I want to share it with you. Now, if we were to call someone a degenerate, that's an insult. So in English, it means something like a simpleton, like they can't understand anything complex, or they can't be taught, or they're primitive and immoral. Now, my wife, she's a Spanish instructor, and Spanish is her primary language growing up. So she informed me that in Spanish, the ser, or the to be form of degenerado, ser degenerado, means someone is a person who is a sexual deviant. If I were to say, tú estás degenerándote, that means more like you're kind of losing ground or you're regressing. In math, a degenerate case is a statistical term, and it's a little bit more difficult to explain, but really that's rarely stopped me before. So let me try. If you make the radius of a circle 0, then that circle just degenerates into a point in space. A point in space is a degenerate case of a circle with radius 0. If you make one of the angles or sides of a triangle 0, then it degenerates into a line segment. It becomes more simple, you could say. But simply becoming more simple or having fewer dimensions is not exactly what I mean here. I mean that there can be an especially large number of different things that can appear to be the same thing. So for example, if you rotate a two-dimensional circle in a three-dimensional plane, when it is exactly parallel to your perspective, it will just look like a line segment. But it's really a circle. The same thing would happen if you rotated a triangle, or a square, or a hexagon, or a trapezoid, or really any two-dimensional shape. No matter how many angles it has, if you rotate it to be parallel to your perspective, then it's going to look like a line to you. Degeneracy as a neuroscience concept is a lot like that. What it means is that a phenomenon does not have to follow a predictable pattern of causation through the brain to appear to be the exact same phenomenon. For example, like a pattern of activity that produces the subjective state of fear can differ enormously between individuals, or even within the same individual. Even if you found a part of the brain that would reliably result in, for example, anger or angry appearing behaviors when you stimulate it, this does not mean that the brain's anger center is the thing you're stimulating, and it certainly does not mean that that area of the brain is necessary to produce everything that appears to be anger. It may not even be involved in a lot of the anger that you experience otherwise. Degeneracy in neuroscience means that you can get the same result in many different ways. So knowing the result does not mean you know the path to get there. As a consequence, this means that for any psychological construct, like depression, for example, even though you can identify it by some functional end state, like a loss of pleasure and motivation, for example, there are many, many different patterns of neural activity that can produce that. It's not just one thing. So as far as we can tell, pretty much all of our emotions are degenerate phenomenon. This helps to explain the diagnostic difficulty that psychiatrists face and why the same treatment mechanism only ever works for just a subset of our patients. More recently, I've faced the diagnostic conundrum of catatonia in autism. And that's what I want to explore in more excruciating detail here today. There is surprisingly little literature on the subject. And that's concerning because being able to identify and treat catatonia can be life-saving, not to mention life-altering for patients and their caretakers. And we're coming to understand that catatonia is very, very common among neuroatypical people and often not diagnosed. But I'll get to that later. Misidentifying catatonia as, say, just aggression or highly limited interests like those in autism can result in exactly the wrong medication being given or no medication being given at all and worsening of the catatonia. Antipsychotics at low doses are often helpful in aggression in autism, but care has to be taken when giving these to someone with catatonia because it can worsen the catatonia. But you may have to. The thing is, you have to know what you're treating. So I want to inspire any psychiatrists listening to be extra sure to rule out or identify catatonia before just reaching for risperidone in an aggressive patient with autism. Starting in March of 2022, I produced a series on catatonia in this podcast, Didactic. During that series, I discussed like a lot of the core diagnostic features and how we conceptualize them, so I'm not going to repeat all of that here. However, it is worth reviewing catatonia from a 10,000-foot perspective, like what catatonia is, so you can understand how difficult it may be to distinguish between, for example, excited catatonia and a patient with autism who's also manic, or who is catatonic and manic. So let's start with describing catatonia and why many of its features might be missed or misinterpreted in autistic patients, especially those individuals that have historically required substantial daily support. So catatonia has been called a movement disorder, and this is evidenced by the fact that we often diagnose it based on movements or the lack thereof. Catatonia has been divided into basically 2 or 3 subtypes. So there's retarded, also known as akinetic catatonia, and there's excited, also known as hyperkinetic catatonia. And catatonia can progress into a type called malignant catatonia, which is nearly indistinguishable from something called neuroleptic malignant syndrome, where patients become stiff, and there's autonomic instability, there's muscle breakdown, kidney failure, arrhythmias, seizures, and often death. The only difference between the two is neuroleptic malignant syndrome results from giving patients antipsychotic medications, whereas malignant catatonia doesn't require patients to have been given antipsychotic medications. And antipsychotic medications can precipitate malignant catatonia. Now, the retarded or akinetic symptoms of catatonia, the slow catatonia, is generally characterized by like a lack of interaction with the outside world, or less than previously. So a patient will move little, if at all, or very, very slowly. They might fail to feed themselves or to care for themselves. They might stare forward and not respond. Or if they do respond, they respond far less than they normally would. A talkative person might just say a few words and then stop. Often patients with akinetic symptoms appear stuck in a position. Like they go to do something and then they just stop. And it looks like maybe they're trying to figure out what to do next. There's also posturing, where a patient just puts themselves into a position and holds it. So you have to be in a position against gravity. You can't just be laying in the bed. That doesn't count. But if you're holding yourself against gravity for longer than seems normal, that's posturing. Now, when someone who is examining a patient is able to move the patient around kind of like they're a modeling clay statue and they stay in that position, this is called catalepsy. And if they feel really rigid the whole time, but you're able to move them, this is called lead pipe rigidity. A patient might also just meaninglessly resist you when you're trying to move them. So you try to move them, but the harder you push, the harder they resist. And you can tell they're resisting you because they're meeting your resistance with the same amount of force. Now, they have no reason to resist. They might even tell you when they're not catatonic anymore that they weren't trying to resist. They simply couldn't help themselves. But instead of fully resisting, they might also provide just initial resistance, and then after you've pushed for a few seconds, they release. This is called waxy flexibility, like you're breaking a candle. The key to catatonia is that these actions appear motiveless to the examiner. Like they don't have the same kind of meaning or motive that a normal person would have who's performing these actions. Another odd feature of catatonic patients is that they just might do the opposite of what you tell them to do. Again, it's like motiveless. They're not trying to do the opposite of what you tell them to do. They just can't help themselves. They might tell you afterwards they had no choice but to do the opposite. So now we're getting kind of into the excited signs or the kinetic signs of catatonia, when patients are actually doing more than they did before. Right? So they might be very impulsive and they have a bunch of meaningless movements. They may jump up and down, run around. They might repeat meaningless phrases. They might just suddenly punch someone without any provocation whatsoever, or they might just start knocking everything off of a table when they pass by. They also might do normal things in bizarre ways. Like when they feed themselves breakfast, they might take their spoon and do a deep dive into the cereal, hold it way up, and then bring it to their face in a really exaggerated fashion. Now, I'm going to stop here for describing catatonia, because I could go on and on and on and on. But I want to get back to catatonia in autism. The prevalence of catatonia is much, much higher in neurodevelopmental disorders and in neuroatypical individuals. In autism, for example, somewhere between 10 and 20% of all autistic people at any point in time have some level of catatonia. This means if you just randomly sample every person on Earth who has autism, about 15% of them will be experiencing catatonia. But in reality, only a small number of them are diagnosed and are being treated appropriately. That's because catatonia in neurotypical people is much easier to identify than in individuals with autism or other neurodevelopmental disorders. The challenge, for example, for autistic individuals really is to distinguish catatonia from many of their baseline autistic traits. This could be even more difficult if a patient presents with excited or hyperkinetic symptoms, if they're doing a lot, because these are often present in autistic individuals kind of intermittently. There are things called stereotyped movements or stereotypies, and these are movements that occur. They appear to have no purpose at all. They are also not tics or tremors, and they're really common among autistic individuals. You might think of like hand flapping as a stereotypy. There are also mannerisms, and these are just kind of odd ways of doing purposeful things. And these are also common in autism. So it's doing a purposeful thing in a way that just seems odd and not something normal, or the normal way that they would have done it before. There are quite a few things to consider when you see new things coming up in individuals with autism or individuals with other neurodevelopmental disorders. Are these new symptoms? So are these symptoms not typical of that individual? I mean, even if you might expect some of these movements to happen in autistic individuals, has this individual had a history of that movement? If not, that's new and that's concerning. You also need to ask yourself about the intensity or the frequency of the symptoms. Has it been increasing over time? Is it sustained, or does it happen every now and then just kind of go away? Also, does the person seem to perseverate or repeatedly do that thing even though they've been redirected away from it? Another thing to consider is if the movement is just kind of bizarre or completely out of character for this person, like they're just walking around and suddenly they are kicking strangers that they walk by, or suddenly throwing furniture. And this wasn't something that they ever did before. Finally, if any of the symptoms are associated with a failure to care for themselves, especially not the way that they did before. Maybe they still do some things, but not as much. They're not eating as much. You have to remind them to do things they used to do a lot. This is concerning. So not caring for yourself the way you used to be able to is a big red flag for catatonia. And often there's really a kind of prodromal or kindling phase. So they might develop movements that are kind of smaller. Maybe you don't really notice them until after the fact. Like in hindsight, you're like, you know what? They were doing something different. You know, like eating less or making less eye contact or kind of staring into space. There are new movements in some individuals that do resemble tics or will be called tics in the early phases of becoming catatonic. Um, Especially like facial tics, which can look like facial grimacing. Now, a tic is when the face just kind of moves. Grimacing is where it moves and you hold that position for longer than expected. Also, patients might start doing like shoulder shrugs or moving their body in a way that just wasn't typical for them before, but isn't exactly bizarre. Some features may also appear to be like obsessions or compulsions. And so a person with a neurodevelopmental disorder might get a diagnosis of OCD even though they have catatonia. So anytime you're considering OCD, try to rule out catatonia. If the autistic patient has been on long-term antipsychotics, especially they have aggressive behaviors or unmanageable actions, and the antipsychotics have helped a lot, then any new unexplained movement might be mistaken for tardive dyskinesia, or it might be tardive dyskinesia. So you have to consider both of those. Now, the movements in tardive dyskinesia are purposeless. They often start with kind of facial movements, so maybe tongue protruding or the jaw kind of moves to the side. You may have movements of the upper extremities, and there's often movements of like the paraspinal muscles or the hips. So all of these can be present. And if those are the only things there, tardive dyskinesia would be higher on the list. But if it's also associated with any other catatotic signs, then think catatonia. Especially if there's kind of a regression in the person's ability to interact with the outside world, communicate in any way, care for themselves. I mean, that's really highly suspicious for catatonia. And it might be interpreted as depression. But the two conditions are not mutually exclusive. In fact, catatonia is very common in mood disorders. In fact, it's most common in mood disorders compared to any other psychiatric disorder. Probably the most common thing that causes catatonia is some sort of medical disorder, but the second most common thing are mood disorders like depression and bipolar. Catatonic patients might also have difficulty sleeping. So it might appear that they have mania, but they're not actually doing anything. They might just be sitting there in bed, eyes open, staring forward, not sleeping. Also, catatonic patients might start just refusing to do things that they otherwise would have done before. They might become oppositional, or they might just do the opposite of what it is you're asking them to do. You also might notice that, and this is probably a big one, they are doing things they used to do, but now it looks like they have to put in a lot of effort to do these kind of simple tasks, like things like brushing their teeth or feeding themselves or opening and closing a door, walking around, especially on uneven ground or going up and down stairs. You might see them start to hesitate because they're having a hard time coordinating their body to move. You know those board games that have complicated folding boards? So if the patient used to be able to fold that up, let's say, for example, they played this game many times and they were able to open it up and unfold it and then put it away. But then they find it difficult suddenly to fold it back up and put it away. That's concerning for catatonia. Another thing different between people with neurodevelopmental disorders and more neurotypical people is that the prognosis during the treatment for catatonia can be very different, because catatonia is often, or more often, chronic in patients with autism. It can be harder to treat to remission and be more likely to recur even without warning or without any other underlying etiology like a medical issue. So it may take weeks or even many, many months to treat them back to their baseline or to as good as they're going to get. So of course we start with lorazepam. You give that. But after they've stabilized, it might require switching to a longer acting benzodiazepine for maintenance, because one, it's easier to give in outpatient, and two, it might provide more even control without breakthrough symptoms. There are not many controlled trials in catatonia in general, and even fewer in autistic individuals. So it might be necessary to just rely on case series describing responses to treatments in other patients. So some case series report that autistic individuals often require additional medicines more than just Ativan, and there are variable ways that this is done. I'm going to go ahead and link to two presentations available on YouTube at sidactic.buzzsprout.com in the show transcript if you're interested in these. Some of the providers will add amantadine or memantine, which is often done in neurotypical people as well. So benzodiazepines like lorazepam, they work by stimulating GABA receptors, which has the downstream effect of blocking glutamate release, for example. And this reduces the excitability of the neuron that it's communicating with. Amantadine and memantine are NMDA or glutamate receptor antagonists. So instead of stopping the release of glutamate, they just block the receptors that glutamate would hit. So this might complement that increased GABAergic transmission that you're trying to get through by adding the benzodiazepine. Now, if there's self-harm, and frequently there is, you can add on N-acetylcysteine. So this is often given to children to reduce self-harming behaviors. So it's reasonable to try in an autistic patient, maybe not even a child, just any autistic patient who has catatonic features, who has started to maybe pick their skin or pull their hair or hit themselves. There can also be emotional incontinence, like sudden inappropriate laughter or crying or anger or like writhing on the floor in apparent pain, but there's nothing causing that pain. So when people have emotional incontinence, we call that pseudo-bulbar affect. And there is an FDA-approved treatment for that. It's called Nudexta. And Nudexta is a mixture of dextromethorphan and quinidine. So dextromethorphan is an NMDA antagonist, kind of like amantadine and memantine, but it's also a sigma-1 agonist. And it usually can't cross the blood-brain barrier very well, but if you block its metabolism, then it can reach high enough levels in the blood to cross the blood-brain barrier. And this is what combining it with quinidine does, because quinidine is a CYP 2D6 inhibitor. So it increases the blood levels of dextromethorphan and more of it is available to get into the brain. Now this is also similar to another drug that was recently approved called Velity, which mixes dextromethorphan with bupropion for the same reason. So bupropion is a CYP2D6 inhibitor. So it increases the blood concentrations of dextromethorphan so they can get into the brain. And this is supposed to treat treatment-resistant depression or suicidality, to get kind of a more quick response in a patient who is depressed and suicidal. Also, anticonvulsants have been tried, things like valproate and carbamazepine. They can be used adjunctively as well. Now, I have in the past seen IV valproate used in an attempt to kind of break catatonia, and this was in a more elderly patient. In that case, it wasn't effective, so we went ahead and used lorazepam. But the idea was we would try something that is not a benzodiazepine, because this person was somewhat frail, but it didn't work. But it can be used adjunctively and added on. There are a lot of possible etiologies for catatonia. Like I mentioned earlier, catatonia is almost certainly a degenerate process. So using anticonvulsants in some instances is reasonable. Now, the gold standard for treating catatonia is ECT, electroconvulsive therapy, and there are remission rates as high as 80 to 90% in the trials they do. It's highly effective. And it may be tempting to try to treat for months and months before you actually try ECT, but waiting to prove treatment resistance might also prolong someone's suffering. So if you can find a place that will do ECT in children, which is difficult, don't wait too long to start ECT, because it's probably just going to prolong the suffering. And ECT can treat catatonia as well as any underlying like mood disorder. So ECT is super effective at treating depression and is very effective at treating mania as well. And it can help improve psychotic features that are associated with mood disorders. Now, ECT doesn't treat psychosis all by itself. It's not very effective for just psychosis, but if the psychosis is associated with a mood disorder, ECT is very effective. So we can shock away mania, we can shock away depression, and we can shock away catatonia, but we can't shock away just psychosis. So. Now, there are case series in neuroatypical patients that report significant responses to ECT within about 3 treatments. And often further treatments are needed for full resolution. And sometimes you need less frequent but intermittent maintenance ECT to prevent relapse into catatonia, but you won't know exactly what you need until you try it and you see what happens. Another thing you have to do when a patient is catatonic is track their symptoms, and most providers know of something called the Bush-Francis Catatonia Rating Scale, but the Bush-Francis was not designed or even tested that I know of in neuroatypical patients. There is a scale called the Kanner scale, and there's also something called the Catatonian Impact Scale. And both of these scales are supposed to be better for like patients with autism or with Down syndrome or other neurodevelopmental disorders. Now, if you just need to make a diagnosis, the Bush-Francis is still very reliable. So you can use the Bush-Francis to diagnose catatonia anytime, but in neuroatypical patients, to track daily progress, it's probably better to use the Kanner. And you can do both the Bush-Francis and the Kanner at the same time every day. Now, when the patient is at home in the outpatient setting, that's a lot for parents to do, and they may not actually be able to do that without some pretty extensive training. So what you can give them is something called the Catatonia Impact Scale, and this is designed for caregivers of patients who have catatonia, and they can kind of average over the week the frequency of different symptoms. And this is very helpful when they're following up with outpatient providers to be able to give them like numbers. Like this scale says that actually doing better, or over the last 2 weeks, the numbers are getting higher. I think we need to make some medication changes. One thing that especially caregivers will ask you is like, when will I know if we need to go to get ECT? Like when would that be a thing we have to do? So there can be some pretty dissatisfying answers, like say, well, if there's not enough response to the medication. Well, what is enough response, right? So there's some fuzziness there. Or you could tell them, like, if progress halts, like we're making headway on average, the person's getting better, but then we have a week or 2 weeks where they're not getting any better anymore. That's when we would consider ECT. You might also consider ECT if there's a severe underlying mood disorder, like if the patient is floridly manic, or if they appear to be severely depressed, or if the catatonia itself is severe and they're withdrawn and they're not eating and not taking care of themselves. That's definitely a time when you should just kind of go get ECT, not wait a long time for a response to lorazepam. Another time you might want to get ECT is if the catatonia starts to worsen despite the fact that they've been treated. So that might be a time where you say, hey, let's go get ECT and break this worsening and then continue the meds for maintenance. Another time to get ECT is if the patient develops autonomic instability. So this is sort of a sign that they're progressing into malignant catatonia. So they may have changes in blood pressure and heart rate. They may have just start sweating, get flushed. These are signs that things are getting bad. So you would take their blood, you would look at their CK levels, the creatine kinase levels, and if these are high and they are trending up, then that's a time to just go get ECT because the patient is at risk of developing malignant catatonia. Another time to consider ECT is if the patient is very, very hyperactive, very kinetic, and they're having kind of uncontrolled muscle movements, and there's concern that they're just going to exhaust themselves and might develop rhabdomyolysis. That's a time to consider getting ECT sooner than later. I hope that this episode has helped anyone who is working with patients with neurodevelopmental disorders like autism to be able to better recognize and treat catatonia. Well, first, just to think this could be catatonia, and then to tease it apart from what are the patient's baseline behaviors. Catatonia is often right under our noses, and we don't even see it. If we can see it, we can treat it, and we can improve thousands of people's lives. Thank you for listening. I am Dr. O, and this has been an episode of Psydactic.